This next presentation is going to be a very different presentation. What we're going to be looking at is a new paradigm. I'm a Ph.D. neuroscientist, a Ph.D. neuropsychologist, and basically we're going to be looking at novel ways of being able to assess brain functions with relation to electrical activity, magnetic activity, chemical activity, and these neuromarkers that are now being developed. And our organization has been taking a lead worldwide. We have a lot of partnerships through various medical centers on the East Coast with NYU School of Medicine, with Harvard Medical School, and overseas. Thank you.
Go forwards, just to the right.
Okay.
Backwards is to the left, just in case you get too far.
Okay, so forwards to the right, backwards to the left. There was the laser here.
There was no.
There's no laser.
I'll change the batteries out. It's dying on me.
Okay, dying away.
Right back.
That would be helpful. Okay. All right. So, So we're going to be looking at ways in which we could better understand clinical neuromarkers. Typically, we look at various symptoms and we look at various syndromes from a clinical perspective, but we don't have a means of looking at brain activity. And functional neuroimaging has now come a long way, but functional neuroimaging has been used more for specific research studies and not to guide treatment or predict recovery. So we are developing multiple algorithms to understand how to predict recovery and how to guide treatment. And I'll show you at the end some very interesting work that we're doing with coma, vegetative, minimally conscious patients, which we'll get into a little bit later. So we're looking at what these neuromarkers are, how they're measured, some theoretical framework of reorganization in regard to neuroplasticity, and then looking at the techniques that are employed in changing the brain environment, neuromodulation. So essentially, a neuromarker-driven neuromodulation program, which is a fancy way of saying, finding what's wrong and then being able to get the techniques that are appropriate to fix it. If we look at magnetoencephalography, If we look at magnetoencephalography and spectral EEG, QEEG, evoked potentials, event-related potentials, when we look at electrical and magnetic components of brain functions, and we understand the markers involved, then we can incorporate various means of changing electrical and magnetic environments in the brain. So we can use electrical stimulation techniques, non-invasive electrical stimulation techniques like transcranial direct current stimulation. We can use techniques like repeated transcranial magnetic stimulation to the brain, and other techniques that help to change electrical and magnetic systems, including neurofeedback, median nerve stimulation, etc. And then we'll look at this multimodal care protocol that we put together for vegetative state and future directions of some of the Department of Defense research that we're doing. The International Brain Research Foundation, which I direct, is an organization that's 5 years old. We have 175 scientists worldwide, and we investigate 3 areas, mainly neurodevelopmental disorders, including autism spectrum, ADD, learning disabilities, etc. And on the other end of the spectrum, diseases of the aging brain, normal aging and the aging brain, including Alzheimer's and other degenerative disorders of the brain. And then we have a whole section looking at traumatic and non-traumatic brain injury and disordered consciousness. Okay, so what are neuromarkers? We will develop and have developed objective measures to be able to understand brain function, brain structure, brain chemistry, and these markers can be used to improve our ability to differentially diagnose. It's interesting because a sign is something observable, obviously, from a clinician. A symptom is something that the patient tells you they're experiencing. But when you have patients who have significant damage to the brain, oftentimes due to perceptual, cognitive, or motor difficulties, they're unable to express themselves appropriately, aphasias, apraxias, agnosias, etc. And especially in the population of severe brain injury, where we have altered states of consciousness, coma, vegetative, minimally conscious states, the patient's lying there and not moving. And there are very limited ways that you can assess function. There are certain protocols that are used with rating scales, coma rating scales, and consciousness scales. But there are issues, psychometric issues regarding validity, reliability, and the process in which we do, determine the integrity with those scales requires that certain things need to happen within a certain time frame. And that's very interesting. I just want to give you a little caveat. When we started some of this work, it was based on animal work I did over 25 years ago at NYU School of Medicine, where I had a theory about certain chemical changes that may be taking place as a neuroprotective effect in coma. And we were looking specifically at inhibitory agents in the brain, which we'll talk about later, which essentially shut down agonist neurotransmitters cortically and subcortically. I'll show you a diagram on this a little bit later. And by influencing those various neurochemicals, we can potentially change this brain environment and bring consciousness back. When we woke up 2 cats doing this and videotaped it and presented at grand rounds at NYU, and it was a packed audience and it was a great response, but nothing happened for 25 years. And then 5 years ago, an individual from Virginia, very wealthy individual, was going in for a 5-vessel bypass surgery. This bypass surgery was complicated by the fact that he was obese. He was not very old, he was 68, generally in good health, but obese, had some diabetes and cardiovascular issues. One day post-surgically, he ran into respiratory distress in the middle of the night, and they tried to intubate him. There's a very good hospital down in Virginia. And what happened was they esophageated him. And he had a documented, and I was involved in this case as a consultant, he had a documented 47-minute anoxic event. He was in a vegetative state for 6 months. And we took a look, at his brain through the eyes of MR spectroscopy, spectral EEG analysis, QEEG, evoked potentials, event-related potentials, and we have a monitor that's used in anesthesiology. I guess you guys may use it as well, a BIS monitor that measures depth of consciousness. You may use it. And based on that data, he looked a lot like the cats. The brain functions electrically and chemically look a lot like these cats that we induced an anoxic injury 25 years earlier. So the issue was, could we awaken him by doing these non-invasive neuromodulation techniques? And we never did this in a human before. So the big hurdle was to get an emergency IRB approved at NYU to accommodate this. But then the bigger hurdle was having the dean of the medical school approve a compassionate kind of treatment protocol using this new multimodal treatment protocol, which would require taking up an ICU bed for months. An ICU bed costs $25,000 to $50,000 a day, at the hospital, and they're covered by insurance. But coma, vegetative, minimally conscious state, is not covered by insurance, just so you know that. So that if you are brought into an emergency room from a car accident, a toxic exposure, a cardiac event, or some other process that results in altered states of consciousness, once they stabilize you, if you don't resume consciousness, then you're sent to a nursing facility. There are no DRGs. The regulatory, diagnostic regulatory guidelines from the insurance industry basically drive CPT codes. So there are no CPT codes to treat coma, vegetative, minimally conscious state, because there's no treatment when you stay in prolonged states. We've developed a treatment which we've used successfully, and we've awakened 43 out of 52 individuals in the last 5 years who were extremely vegetative. We have a paper that's coming out. One paper came out to understand this paradigm in the Clinical Neuropsychologist Special Edition for brain injury in December. And another paper is coming out where 28 of 41 patients who had emerged, and it's actually 30 because 2 more emerged after we submitted the data to the article, but we didn't want to revise it. It's coming out in the Restorative Neurology and Neuroscience. And the database that we have now in the last 5 years, we have an 84% recovery rate for prolonged vegetative and minimally conscious states, and the national average is 5 to 10% recovery. But every time we awaken someone, the neurologist says it's a fluke. So we're collecting a lot of flukes. I usually ask them, how many do you have? And they don't have an answer. So neuromarkers can be used for anything. It can be used for infectious encephalopathy. It can be used for toxic encephalopathy, things that were discussed previously, by great work, with Boyd Haley, with Dr. Jaffe, a lot of individuals who work in this area. But toxic encephalopathy, infectious encephalopathy, traumatic and other forms of non-traumatic encephalopathy can all result in altered states of consciousness in extreme forms. So we want to take these electromagnetic, chemical, metabolic, and other components of functional imaging and use them to improve differential diagnosis, to help us better subtype these disorders, predict treatment outcomes, and track the recovery. So part of this we already talked about, providing neuromarkers to develop an integrated brain map. What we have in our group of scientists, outside of what you would think of traditionally in neuroscience as having, Ph.D. neuroscientists, neuropsychologists, neurophysiologists, neurologists, neurosurgeons, etc. We have some of the top mathematicians, computer engineers, biomedical engineers, physicists from around the world who are developing models to understand brain injury, traumatic and non-traumatic, as well as looking at the different technologies and being able to link in these integrated maps various components of electrical, magnetic, and chemical activity with regard to functional integrity and deficit. We have a functional integrity / deficit matrix that we developed. So EEG, spectral EEG, QEEG, evoked and event-related potentials, near-infrared spectroscopy, magnetoencephalography, and this is a really big area, and a lot of the studies I think that you guys are interested in looking at the nucleus of the cell, the plasma, the energy, the neural substrates for neural viability, etc., can all be determined through MR spectroscopy. There are algorithms that have been developed, and we're further developing on these algorithms. Also looking at DTI, SWI, DWI, the various components of weighted imagery, and understanding the white matter tracks in the brain, and looking at diffusion tensor imaging to understand that, as well as various mechanisms to look at autonomic nervous system functioning and levels of consciousness. So electrophysiological neuromarkers that we've been able to look at and report on include alpha peak frequency measurements, bandwidth power measurements, hyper and hypo coherence, which is a functional integration of electrical activity in the brain, as well as different amplitudes of P300. And this is a cognitive brain wave, the P300 wave. 300 milliseconds after something is introduced visually or auditorily, we see the emergence of a P300, which shows that the brain's actually processing this information. And I'll tell you an interesting little aside. About 4 years ago, when we were starting to look at this, I was examining a coma patient, well, a vegetative patient. And basically, when I went into the room, I started to talk to the wife, and this gentleman had been in coma for, many months. The guideline from the American Academy of Neurology is if you're in coma for a period of 3 months with an anoxic or a metabolic injury, and you have a Glasgow coma score between 3 and 9, which is a severe deficit, that it's close to 0 probability for recovery. And with traumatic brain injury, the same guidelines are there for 1 year in this state. So these individuals that we get are extremely vegetative, and they're beyond their expiration date, so to speak, that we've aroused. But this individual, when I came in to evaluate him, I was interrupted about 5 minutes into discussion with his wife by the neurology attending, the neurointensivist, and the team of residents, fellows, medical students, etc. The whole entourage came in, and they wanted to do, a neuro exam. So I said, fine, go ahead. I stepped back, and they, quickly went through, the attending quickly went through asking this individual to open up his eyes, squeeze his hand, Mr. So-and-so, do this, do that, went through reflexes really quickly, and then stepped out of the room after about maybe 5 minutes, I guess, of an evaluation of this individual, and was talking to the residents and medical students in earshot of the wife, and said, this is an extremely vegetative patient, has been past the time period for recovery, it's 0 probability of recovery, this guy's never going to wake up. However, you can come in and look at X, Y, Z, reflexes, and check this and that, and these are the kind of markers that we look at clinically. Then they started to walk down the hall. The wife started to cry, and she said to me, well, what are you doing here? Because, this doctor's saying you can never wake up, so what's the purpose of being here? So partially in trying to be a psychologist for this individual, and partially to collect some data to see if this person would potentially be a candidate to wake up, I said, well, look, I would do things a little bit differently. One thing I would do, for instance, would be, I took the husband's hand and I said, Mr. So-and-so, I'm squeezing your right hand. I'm squeezing your right hand, I'm squeezing it harder, I'm squeezing it very hard. If you feel it, you feel your right hand being squeezed very hard. Now I'm letting go of your right hand. And I did this 3 or 4 times. Then I said, I'm going to hold my hand in your hand. And before I did that, I checked for, reflexes, abnormal reflexes, frontal release signs, so, to make sure that this person doesn't have an abnormal grasp reflex, which he didn't. And kept my hand in his hand and looked at the clock, and then had a little conversation with the wife, and about 8 minutes went by. And I started to feel a slow, steady pressure in my hand. I said, gee, that's interesting. Feels like you're starting to squeeze my hand. So I said, okay, Mr. So-and-so, keep squeezing my hand. It took about another 5 minutes to get a really good grip. And it took 15 minutes to release. The team that came in that did the evaluation finished rounds and was eating lunch by now. And I said, this is very interesting, I was thinking to myself, because of the latency in response. See, we look at 300 milliseconds, as a certain response. When we don't see this positive 300 millisecond response, we think that there's no cognition taking place. So I put together a protocol, actually at lunch that day on some napkins with a colleague of mine, to say, what would we do to try to differentiate if someone is understanding a motor command versus visualizing versus feeling something. So this protocol included playing tennis with your right and left hand. And the person's not going to move their hand when you say it, if they're in a vegetative state or a minimally conscious state, but the premotor and supplementary motor areas may light up in the contralateral side to that motor region to show that the brain's processed the command and is ready to execute the motor command, even though they're not able to execute the motor command. And then we did the right side to see if we had lateralization function the opposite side. And we did the same thing walking through your house, looking at going through every room of the house and having the spouse tell us what the house looks like and walking the person through the house auditorily, having them revisualize and seeing various regions of the brain that would light up in that process, etc. So we went through this process and we measured in patients whether or not these patients in vegetative state had some ability to communicate. And 6 of the patients were able to show differentiation clearly in electrical imaging studies. Now I was supposed to present this in Istanbul, and as part of another study, but we were presenting our first 6 patients that emerged from consciousness who was never supposed to emerge, and that was mainly the presentation. But at the end of the presentation, I talked about the possibility of people being able to cognitively process during a vegetative state. You know, sometimes we remember our dreams, sometimes we don't. Some people will, some people won't. Most people don't, but some people do. And we wanted to figure out, do they really, and how can we tell? So, at that meeting, I didn't report on the 6 patients because the chairman of our neurology department is very conservative, and I was a professor at NYU in the neurology department, and he said, you know, I know that you're very excited about the findings, but don't present that NYU is communicating with people in vegetative state until we have a larger N. I said, okay, relax, it'll be okay. So, at the end of my talk, waking up 6 people out of coma, I said, by the way, we're doing this, and there's a 40% misdiagnosis rate, by the way, of vegetative versus, you know, minimally conscious states, locked-in syndrome, a whole other area where people can't move, but they can process. You need to differentiate the two, which you can do with EEG and other functional imaging studies. So at the end of this, a group from Oxford approached me and said, wow, that's really interesting. Maybe we can talk, have lunch. We're interested in doing this. We use fMRI, which is a lot slower than EEG. Within seconds, you can see with quantitative EEG and MEG, whereas there's a much bigger latency with fMRI. But they wanted to do a study. I gave them the model, and I said, contact me. And I told them about, you know, this little protocol I put together on napkins at lunch. Never heard from these guys. 6 months later, there was an article in Nature with an N of 1. An N of 1. Nature accepted the article, and it was on the front page of like 40, 50 newspapers worldwide. Doctors communicate with coma patients. So I looked, I got 8,000 emails, and it was this group that used my protocol and never gave me any credit for it. After I got over the, you know, the agitation of this all, I decided the positive piece of this was that we just had what we looked at electrically confirmed through fMRI technology, even though it was an N of 1. But the thing is, functional imaging capabilities are much more powerful. The algorithms that are being developed to understand changes in brain function in relation to chemical, electrical, magnetic shifts that are taking place in the brain are very important in understanding what's happening during recovery processes. And you know, you don't see a lot happening in a patient for a long time. They're laying there maybe for a month or two, and then all of a sudden things start to happen. Well, a lot of things are going on in their brain during that month or two, and we see it on the functional imaging data. It's just like, you know, I use the analogy of a pregnant woman. You know, when someone's pregnant, you don't see anything for a while, and then all of a sudden you see, you know, the emergence of the person's abdomen in relation to the fetal growth, but a lot of things were happening before that ever emerged. You know, and you actually saw some physical sign of someone being pregnant. So a lot of things are happening with regard to arousal levels, attention, information processing capabilities, et cetera, that are going on in the brain clinically. Okay. So our organization, International Brain Research Foundation, if any of you are interested in doing research and using functional imaging methodologies and want to be a part of our, you know, research group, become a consulting scientist in our research group, certainly contact us. It's www.ibrfinc.org, and we have multi-million-dollar grants for different things that we're looking at currently. But IBRF methodology assesses functional connectivity through coherence and phase measurements measured by quantitative EEG. We use specific methods to understand electrical connectivity known as coherence, and we're able to look at various sources in relation to coherence, and we correlate the frequency spectrum, the amplitude and waveform morphology in frequency and phase, and look at the representative share of activity between specific regions of interest in relation to these different components to be able to understand how the brain is interconnecting electrically. And with phase, we see similar waves formed occurring at the same time in two different sites, and measuring the time delays between the sites and which structures are involved. Okay, this is just, I'm not going to have time to go through all this stuff, but this is just localization capability, looking at hypo and hyper coherence and power in the different three-dimensional reconstructions based on EEG imaging sources. And here's three-dimensionalized evoked potential, event-related potential, looking at processing speeds of both P3A, P3B, and looking between group differences of different processing speeds cognitively that are occurring within the brain. Near-infrared spectroscopy is really important because one of the modalities that we use is a median nerve stimulator that increases blood flow to the brain, which causes increase in oxygen and glucose consumption. And we look at the level of oxygen that is being bound through near-infrared spectroscopy. And typically, people in altered states of consciousness have about a 20% diminution in oxygen carrying capability because of inadequate metabolic activity that's occurring. And we directly assess brain metabolic functioning through oxygen consumption with NIRS. Very important, and MEG is extremely important. There aren't many MEG scanners around. They're expensive. You have to build a huge room. There's a lot to it. It's a sophisticated methodology, but interestingly, we're learning that there are rhythms between the thalamus and the cortex, these thalamocortical rhythms, that are very important in understanding high-level cognitive processing, especially the gamma range of 40 hertz, and looking at coherence with MEG, and analyzing and comparing through SPECT and PET, the thalamocortical dysrhythmia between, here's the dorsomedial nucleus of the thalamus and the dorsolateral prefrontal cortex, looking at cognitive capability. But the MEG scan can reveal 2/3 of the electrical activity within the cortex that EEG cannot access. And the 1/3 of the rhythms that EEG accesses, MEG can't. So we combine a MEG, QEEG, EEG, QEEG, evoked potential, event-related potential paradigm to look at the whole spectrum of magnetic and electrical activity cortically and subcortically in these individuals. A lot of work that you guys are interested in with toxic encephalopathies really can be looked at through MR spectroscopy. I think looking at the physical spectra of various chemicals and providing quantitative estimates of the concentrations of specific chemicals in specific regions of interest would give us a lot of data with regard to these toxic encephalopathies, and we can localize, through 3T and higher MRS scans, single voxel localization to regions of interest, measure metabolic concentrations of neurochemicals, predict recovery by subtyping, and then eventually guide. And we use, I was very impressed, you guys are very into nutraceuticals. Nutraceuticals is a better way to enable the brain to synthesize many of its neurochemicals. Pharmaceuticals do it much quicker, but pharmaceuticals create a lot of problems with long-term use. They burn out receptors, cause a lot of side effects that create a lot of difficulties with the brain. So what we typically do with our patients in these states is we use multiple pharmacological agents based on MR spec data, and then those agents either substitute or prolong the half-life of these various agonist neurotransmitters in the brain. And then we, after 3 or 4 weeks, when we titrate up dosages into the ranges that we want them, then we start our nutraceutical protocol. And 3 or 4 weeks of titrating that up, and what we do over time is we titrate down the prescription medications and maintain the nutraceuticals. And we find a very beneficial effect. And there's a really good synergistic outcome between appropriate use of prescription medications with nutraceuticals if they're combined properly. And that's something that we're doing, which most medical doctors don't understand. They don't understand nutraceuticals, unfortunately, and only use prescription medications. Okay, here's MRI DTI data looking at weighted and local microstructural characteristics of water diffusion. These are the kinds of data that we see with relation to white matter tracks, looking at directionality, integrity, and nerve fiber bundles. And in addition, we do a whole assessment of the brain stem, autonomic nervous system, which a lot of our colleagues in Europe are working with us on. Dr. Max Hiltz leads this area. We work together. This is the BIS monitor I was talking about. This monitor is used by anesthesiologists in the operating room to look at levels of consciousness with depth of anesthesia so that they can predict, how much anesthesia they need to give for the duration of the surgery and then wake up the person at the end of the surgery. So it looks at, there's an EEG index that looks at consciousness through this BIS monitor and has different ratings from depth of consciousness and deep sedation back to full consciousness. So one day I said, well, why can't we use that to measure recovery from coma, vegetative, minimally conscious state? And that's what we did. We adopted it for that, and we found good results with doing that. So the ability of the brain to change and adapt over time, structurally, chemically, functionally. Think of this: neurons that fire together, wire together. When individuals start to recover from major brain insults, sometimes seizure activity occurs. We think that's good, actually. Then we see some seizures, because what's happening is the brain's starting to reintegrate, it's starting to reorganize itself, but it's misfiring. So we have to regulate it and get it to fire appropriately so that there's no seizure activity. So we control seizures, but essentially that's a sign that the brain's starting to reorganize itself electrically. And with regard to neuroplasticity, we look at various mechanisms. I'm not going to have time to go into them, but long-term potentiation, long-term depression, membrane excitability changes, and finally anatomical changes, looking at both axonal terminal increases and number of synapses are ways that this is measured. Long-term potentiation basically is looking at, in CA3 cells, repeated stimulation in the number of glutamate receptors on the CA1 cell increases and the receptors become activated. If the original stimulus is then reapplied to the CA3 cell, the resulting glutamate release will induce a much greater response in the CA1 cell. This is basically called long-term potentiation. The effects are here, where you see the difference in density of the fiber pathways. And examples of neuroplasticity in the anatomical changes, you see neurogenesis with endothelial cells secreting BDNF to stimulate neurogenesis growth and development of neurons, and neurons in turn secrete vascular endothelial growth factor to promote angiogenesis, the growth of new blood vessels to bring blood to newly developed nerve tissue. Now, let me just give you an example of something. We tend to think about the volume of nerve cells as being really important. We have about 100 billion nerve cells in our heads. We also have about 100 billion nerve cells in our gut, which is interesting. So you have sort of like another brain in the gut region. Now, these 100 billion neurons in the brain are always looked at in relation to volume. So if someone has an injury, if someone has a degenerative disorder, they look at loss of cells. And essentially, they look at increase in, CSF, ventricular size, dilatation of sulcal space, being indicators of loss of brain volume. And that's an important factor. But what's more important is the neurochemical environment of the brain and the white matter tracts and glial cells. And people typically don't look at any of those parameters. We're finding that that's actually more important than volume. And I'll give you an interesting anecdotal little aside here, a story of a gentleman from England about 15 or 18 years, or maybe 20 years ago. This was published in Lancet in Britain. This guy went to get a CT done in his brain, subsequent MRI, for very severe headache syndrome. He was a senior executive in a large corporation, and he had this headache issue. By the way, less than 2% of the world population has had their brain scanned. So all the data is based on, 2%, less than 2% of the world population in looking at structure, brain structure. This individual I wish I was there because I would have probably been shocked as well. This individual had the brain the size of a walnut, actual brain volume, parenchymal tissue. The rest of the space in the cranium was filled with cerebrospinal fluid, but there was a very large amount of glial cells and dense, very dense white matter within this small amount of brain volume. And people could not figure out how this individual is even alive, but this individual is a highly functioning executive in a large corporation. So the volume of cells may not be as important. We lose about 20, 25,000, maybe 30,000 brain cells a day, depending upon what statistics you look at, from the time the brain's fully formed in late adolescence till the end of senescence. So by the time you're 70, 75 years old, you lose maybe 20% of your brain volume. So the thing is, we look at the bimodal distribution in the elderly population as a parameter of volume loss, looking at mild cognitive impairment, MCI, versus dementia, versus normal aging. So we look at the stratified group of elderly individuals based on brain volume. But brain volume loss is only one piece of the whole matrix here, and the picture is not, that's the picture that's looked at. We have 6 patients that we piloted now through IBRF research that we're doing on senile dementia, of people with moderate to moderately severe dementia based on clinical diagnosis by the neurologist and based on films, CT, MRI, PET, okay? And if you look at the films, they're very scary looking films of the brain. What we did is we used neuromodulation. We used non-invasive neuromodulation, transcranial magnetic stimulation, transcranial direct current stimulation, median nerve stimulation, a number of nutraceuticals based on MR spectroscopy, and neurofeedback and cognitive enhancement software programs in neuropsychology, speech therapy, and various medications combined synergistically. And we had 6 individuals who were bedridden and could not function, very aphasic, all of whom were able to function at a much higher level, 2 of whom returned back to their businesses. Their brains still looked very impaired, but their chemistry, the electrochemical environment of the brain, changed very dramatically on our functional imaging. So the normal structural imaging was poor, but when we looked at metabolic function, when we looked at magnetoencephalography, QEEG, when we looked at MR SPECT, we saw significant changes in the functional imaging that showed that we were able to modify the brain's integrity by changing the electrochemical environment, which maximized the potential recovery of that individual. We didn't stop the disease, and we didn't change. If you looked at the films of basic structure, it looked very poor. When the neurologists looked at the patient's recovery and then looked at their scans, they were in disbelief. So if we can modify the electrochemical environment and maximize the potential of those modifications through neuromodulation, guided by these neuromarkers, we can do things very dramatically with regard to recovery. And this is, if you look at infectious encephalopathy, toxic, metabolic, traumatic, etc., they all follow the same, it's the same brain. And we're looking at neuromarkers and neuromodulation, so the etiology is irrelevant. By identifying the unique characteristics within the brain's electrochemical environment, we can identify and measure neuromarkers. Specific interventions and treatments are then applied in an effort to facilitate and guide neuroplasticity. And this is an article, by me and my colleagues, that was in the Clinical Neuropsychologist in December. Sorry, going the wrong way. Just to go over this briefly, neuropsychopharmacology, my daughter, when she was about 7, saw that journal come in one day and said, "Dad, this is way too many syllables for a magazine." I said, "Yeah, you're right." Neuropsychiatric pharmacology, all off-label use of pharmaceuticals, and in our case, nutraceuticals, is the norm. Because in brain injury, they use typically 1 or 2 medications. We use 10 to 12 medications, and we use 15 to 20 nutraceuticals, some of which are given IV, IM, sub-Q, depending upon what the best, delivery is of these various nutrients and medications. But we've been criticized by our colleagues, although there's now a new paradigm in which there is a way to assess very accurately the use of multimodal treatments in large groups of pharmacology simultaneously. But most people are in a mode where the research from 50 years ago is using one agent. They try to find one agent that would be the magic bullet to help with senile dementia, to help with brain injury and coma, and they haven't found that. And the pharmacology of this has been very intense, with billions of dollars poured in by the pharmaceutical companies. And we use a lot of these combinations of medications that can agonize different neurotransmitters, antagonize others, and nutraceuticals synergistically, guided by the MR SPECT and the QEEG data. And we found good results. And there's the next article coming out in RNN is going to show the 85%, 84% recovery rate. So last week I was speaking at the International Brain Injury Association in Washington, D.C. There were about 2,000 people from around the world. We had a very large group, and several of the neuropsychopharmacologists got up and said, how do you know what's working? We said, well, we really don't care right now because it's the combination that's working. We will break this down in subsequent studies to look at the effects of individual pieces as we start to more accurately analyze these neuromarkers. And they said, well, how do you know that? Well, how do you know that works? Well, how do we know it works? All the other interventions were done. They didn't work. They were beyond their expiration date. We used these techniques, and the individuals got better. I said, look, if you went out, if it was a very cold day, and you wanted to go outside, and you were standing naked in front of your closet, and there were a pair of pants hanging, and shirts, and underwear, and socks, and gloves, and a hat, and a coat, and you said, well, it's really cold out, it's snowing, I'm going to put a pair of pants on and walk out and see if that's good. And you walk outside and you're freezing. So you come back in, take the pants off, put the shirt on, go outside, see the same thing, put gloves on, walk outside. So that's what they do. They give one medication for one neurotransmitter system, and that's what they do. I said, if you put everything on, you go outside, it might work. So the thing is, it's the combination, using appropriate combinations, but the process of using neuromarkers in order to guide neuropsychopharmacology and using nutrients, nutraceuticals, is really important because we can stabilize neurotransmitter systems and we can effectively change brain metabolism by combining various of these nutrients, vitamins, antioxidants with appropriate medications. All right, I'm going to skip this. This is the mechanisms of the neuropsychopharmacology, but I see eyes starting to droop here. It's getting late, and we're running out of time. This is the median nerve stimulator, increases perfusion of oxygen. We measure it with near-infrared spectroscopy. And then we have various cognitive enhancement software systems to improve neuropsychologically attention, memory, cognition, individualizing programs, and other brain-computer interface training to improve different components of electrical signals, whole brain dynamics, and cognition and attention. And this is a BCI training screen. We won't go through that. This is transcranial direct current stim, reduces negative chemical effects, alters cortical excitability, affects neuroplasticity. There's an anode and cathode, so you can excite or inhibit different electrical signals in the brain based on QEEG data. And our multimodal care protocol for severe disorders of consciousness looks at this whole process by understanding neuromarker pattern recognition, personally integrating a specific treatment program, and then looking at specific outcome. I just want to go over this very briefly, and then I'm going to show you a short video. This is a theory that I came up with several colleagues years ago, and essentially, when people are in altered states of consciousness, I was thinking, what's happening? Something's happening chemically to put them in these states, just like the chemicals that occur as we go to sleep at night, the shift in brain chemistry that causes sleep and arousal through circadian ultradian rhythm. Something's going on with the brain that is maybe going into some protective mode, which is causing this coma or vegetative state. So antagonists, inhibitory agents, were things that we were looking at. Inhibitory agents, the main inhibitory agent in the brain is GABA, gamma-aminobutyric acid. The Endorphins is another major inhibitory agent in the brain. So if, and this is what we did with the cats 25 years ago, that we induced coma, if endorphins and GABA, the two major inhibitory agents in the brain, are suppressing cortical activity chemically by downregulating the agonist neurotransmitters to the brainstem to preserve life, and shutting down receptors cortically and subcortically with these inhibitory agents, there is no mechanism to upregulate spontaneously, so most people remain in these states. So what we did is we used two different medicines. We used naltrexone to get at the endorphins, and we used flumazenil to get at the GABA, and did a dose-response curve, and between 90 and 120 minutes, the EEGs went from delta theta back to alpha and beta, and the cats actually got up and started walking around. And we videotaped this. We used this as part of our grand rounds. We didn't have any funding for it. And 25 years later, we improved that by using various agonists in addition to the antagonists in combination with electrical magnetic stimulation and the use of nutraceuticals combined to help people come back from consciousness. This is the N of 41 in the retrospective case study that's going to be coming out in a 12-week intervention with the traditional OTPT speech, off-label pharmaceuticals, median nerve stimulation, nutraceuticals. We could see here the mean standard deviation. These people were 209 days post-injury. 3 months is the cutoff where people are said zero probability recovery. And with pre and post measures, we can see the significant changes pre and post on all the rating scales, showing abnormal back to normal. And we had an 86% recovery rate, where the national average is 5%. So the retrospective results showed a statistically significant improvement across all measures, 100% clinical improvement in MCS patients, 78 to 86% clinical improvement in VS patients, depending upon if it was traumatic versus anoxic/metabolic encephalopathy. And the significant differences between MCP and published literature based on multiple outcome measures shows the efficacy of this protocol. These were just individuals. And here you see no alpha peak frequencies on spectral analysis pre, and then post you see the alpha peak frequency emerge. You see a lot of delta activity in the brain, and then the delta activity goes away, a lot of hypercoherence, and then a reduction in hypercoherence. Same thing here. This is a patient, by the way, that had a 20-minute anoxic event and was in vegetative state greater than 6 months that fully recovered. And this is a patient with a diffuse axonal injury from trauma, vegetative state greater than 1 year, and you can see the changes. There's actually a reverse trend in alpha activity, and then we see the normal alpha peak emerge. A lot of delta, no delta, a lot of hypercoherence, much less hypercoherence. So what we're looking is implementation of these multimodal treatment components in order to assist in changing the electrical and chemical environment of the brain. I went through a lot of these. Okay. What I'm going to do is, because we're just about out of time, is how do I get to the video? Oh, okay. Let me just give you a little bit of information. These are 5 soldiers. These soldiers were in Walter Reed and Bethesda for about 2 years. They then went to the VA Polytrauma Center Emerging Consciousness Program for another year, and they were deemed unrecoverable and being put in nursing homes. We got 1, and then eventually 4 others, because the mother of the first one put out a blog, and other people started to respond. There were about 1,000 military personnel from the U.S. that are now in vegetative and minimally conscious state, both from the war, from IEDs, and being shot in the head, other accidents, crashes, and then training accidents, and also just accidents. Some of them motorcycle accidents, other things. So about 1,000 soldiers. Most of them are combat-related wounds from blast injury. So we used our multimodal approach. The VA, the DOD, was very much against this. They said it's ridiculous, they'll never wake up. We woke all 5 of these individuals up. And now we have 3 more, and we just got a multi-million-dollar grant from the Defense Department for a 2-year study to do this. But this clip, if we could show it, shows 5 soldiers. We put some patriotic music in the background here. My daughter actually picked it out. She's a violinist, and she kind of, I don't know who the artist is. Toby Keith, I think it is, actually. And we got permission from him to use this. But these are 5 soldiers, ages 17 to about 25, that were being put in nursing homes, saying, never will recover. The parents are saying, is there any other method? No, you need to focus on getting psychotherapy for yourself, because there's no treatment for your son or daughter. 2 of these individuals turned back to active duty. So it's just a clip showing different, it's only 2 minutes long, but it's showing the different stages of recovery as they come in. You see them vegetative and then eventually emerging, and then at the end, we picked one of them that, had just left the hospital. So can we do this? Okay. I have a magic trick. No, I'm only kidding. If there are any questions, maybe, or comments or jokes while we're doing this, anything that, sir?
Yeah, I had 3 cases of neural problems in my office. One in which a physicist lost his ability to multiply 2 different matrices in his head at the same time to come up with the right answer. Another patient which lost cognitive function at age 17, and another one that lost his ability to add numbers. And with checking the oral cavity with an oral potentiometer, measuring the millivolts, microamps, and microwatts times seconds, it showed an electrical charge. Now, whether that had some effect on the brain, there must have been something here, because with the removal of the metal fillings, their cognitive functions came back.
It's very interesting.
And I wondered if that could be something for, also investigate with these patients.
I would love to pilot some. We could talk later about doing a potential pilot on that. We're learning right now about the relationship between the electrical system in the heart through the vagal nerve and the electrical system in the brain, in the autonomic nervous system, controlling cardiac output. And we find that many patients with brain injury, even moderate, sometimes brain injury to severe injury, when they recover, there's a subset of these patients that die. It's called sudden death syndrome. And they recovered from their brain injury, and they seem normal, and they're integrated back, and all of a sudden they get a heart attack and die. And we found that people with right hemisphere damage versus left hemisphere damage have higher versus lower blood pressure, autonomic nervous system changes going on. In addition, they have tachycardia syndromes and bradycardic syndromes, right damage versus left damage, which cause arrhythmias. So if we're aware of this, and we do electrical monitoring of the heart, we do a whole assessment of electrical heart monitoring and autonomic nervous system monitoring, and through this matrix we're able to determine those individuals that are at risk and put them on appropriate neuroprotective and cardioprotective medications to reduce the possibility of sudden death syndrome. So there are relationships between the autonomic nervous system and the peripheral nervous system, and there may be a relationship with what you're saying. I can't think of what it would be right now, but I could think of some ways to start to measure that. I think it's very interesting. There was another question, sir?
In Down syndrome children, a number of interventions have helped them improve their mental capabilities, and one of the things that has apparently been helpful is DMSO, which helps sort of integrate workflow and
intermental box. Yeah, that's true. Yeah, and I think that that's very promising. I think in addition to DMSO, I think that using DMSO and other appropriate nutraceuticals directed by neuromarkers, let's say through MR spectroscopy, can help with understanding what the patterns are for those particular individuals, like with Downs and other disorders, so that we can find appropriate neuromarkers that are pathognomonic to certain disorders, which we can then use neuromodulation techniques to change the brain environment. But yeah, DMSO is shown, or other things. I think that's one piece of a much larger group of nutraceuticals and other techniques that can be used, electrical magnetic stimulation techniques, to reorganize the brain environment. Sir?
Have you found specific nutraceuticals to prevent or to help prevent neurological problems or dementia and so on?
We have a whole group, vitamins and herbs and various nutrients. You can email me. I can go over different ones in a breakdown of what they do. Oh, it's IBRF staff too, or one word. IBRF staff, or one word, and then number 2. Sorry about that. But yeah, there are, and it was interesting because the way we first got introduced to this was, I don't know if you guys remember the case of the coal miner from West Virginia that was the sole survivor of the Sago coal mine. We worked with the neurosurgeon, Dr. Julian Bales from West Virginia, with our protocol, and he's doing some mice and rat work with, looking at omega-3. And we give very large dosages of omega-3s. I mean, we give 15 to 20 grams of DHA, and we have different algorithms that we use. But the issue is there are a number of things, and that's one of them, the omega-3, that is extremely important for all of us. I mean, alpha-glycerolphosphatidylserine, alpha-phosphatidylserine. There are a number of acetylcholinergic agonists, which are very important, and dopaminergic agonists that are very important, that we use in combination to maintain sustained perceptual and cognitive functions.
Have you ever tried ozone therapy on any one of these?
Ozone?
Yeah, IV therapy.
What is it?
IV ozone.
No. Maybe you could tell me more about that at some point. I like to learn new things. 3 a day, that's 1, I think, that I'll learn. No, I'd like to talk to you about that. No, never did use that. Sir?
Do you find application of the neuromarkers in addressing pharmaceutical and nutraceutical interventions in genetic illness, in bipolar disease, schizophrenia?
That's what we're doing, and that's what we have certain studies designed that we're getting funded just to do that. Where we have the sound going. They have nothing to do with our study. But that's the whole purpose of what we're doing, looking at different disorders. I'll tell you of a case. There's a very interesting case, just getting on what you're saying. We had a schizophrenic patient, and the chairman of our psychiatry department in NYU, he just retired, he was there for 30 years, was one of the top experts in the world on schizophrenia. And the head of our neuroscience department is probably going to win a Nobel Prize. 2 really brilliant guys. We had a very wealthy guy from Cyprus who wanted to see if his brother can be helped with chronic schizophrenia. 30 years he was in a mental institution in Cyprus, and he was in his 40s. And what happened was this guy, we mapped this guy's brain. We went through all these advanced functional imaging algorithms that we use, and we, interestingly, on the MEG EEG evoked potential algorithm that we use, we found various regions in the frontal lobe of the brain leading down to the amygdala were really problematic. And if there was microsurgery that can be done potentially on these very specific pathways to ablate those pathways, it could potentially reboot the system. Well, there's a neurosurgeon in Switzerland who does these microsurgical procedures on the brain, but never did it on a psychiatric patient before. We provided the neuropsychiatric electrical and magnetic maps to him, and he put together a model that we had our physicists and mathematicians reconstruct and see which areas he would ablate neurosurgically using these microsurgical techniques. And this person actually went through the process of doing this. It cost a lot of money. No one else in the world, I think, has ever had this done to them. Post-surgically, there was no evidence of schizophrenia in this guy. However, about 6 months later, he had a severe depression and attempted suicide. He was reviewing his whole life, seeing that he was in a mental institution for 30 years, never had a job, never had a girlfriend, never had a family, never, had a life, and got very depressed. Now he's doing well. He's in therapy, and he's doing pretty well. But this is a guy who literally had all of his hallucinatory and all the delusional behaviors dissipated post-surgically. So for neuropsychiatric disorders, the use of transcranial magnetic stimulation is being used for depression, it's being used for bipolar disorder, different combinations of medications and electrical stimulation are being used. So these neuromarkers can guide us, I think, in that direction to treat neuropsychiatric disorders in a much more sophisticated way.
How much time passed from the patients who were awakened and then you had a sudden cardiac
It could be as little as a month, and it could be as long as 5 years.
Mom, you say that nice and loud for me? Mom.
We look, maybe we can put this back. Hold on one second. We look at ANS and cardiac electrical systems. We're able, can we put this back?
Yeah.
All right, let's, so this way I can.
doing it.
Yeah, I think you just have to stop the.
Troy,
We're losing the whole thing here.
But you can't do it.
All right.
I'm doing it.
Okay. Let's go back. Maybe we can push that button at the end all the way back to start. All the way at the end. Another one at the end. Go all the way to the end and then just, no, the other, all the way to the end. Right here. If you bring that back here. Oh, that's volume? Okay. There we go. All right.
Okay.
I don't know if we can make this bigger, but this is Kessler Institute for Rehabilitation. You'll show that this guy, there's a rocket attack of a soldier in Iraq, deep coma, vegetative when he came in. And these are 3 years post-injury. This guy was shot in the head. And you can see them at different stages of recovery over time that were taking snapshots of their recovery. And these are all people who were given up on. These people went through Walter Reed, they went through Bethesda for 2 years, they went through the VA for a year, they were being put in nursing homes, and that you can see them at different stages of awakening. This guy lost half of his left hemisphere, had reconstructive surgery done from an IED explosion, blew out half of his left hemisphere. And all these guys are in their 20s. One guy is like 17 or 18 years old. This guy is about 17, in vegetative state when he came, and when he left he was fully awakened and walking, talking, emerged. This is the guy from the earlier guy, the first guy, first week of being awakened. He's much better now, but this is the first week actually of awakening. He's asking him to wave to the camera, and different levels of recovery pattern. This guy had an overdose, a suicide attempt after 3 tours in Iraq, so a lot of combat, had several blast injuries, and then here he is leaving the hospital. I say he would never wake up again, and too bad, I don't know if you could hear it well, but he was with us for 3 months. Oh, there it is, yeah.
And what are your plans from here on out?
Could you push that up a little bit? All right. So that's it. I'm going to stop here. Thank you very much. Appreciate it.